In this presentation, I'll be discussing head injury mechanisms and assessment. The first thing we need to do is kind of get straight on the readings for this module on head injury. And I know I've been calling it concussion assessment, but there are a few other head injuries that we need to consider. You have already read chapter 20 in your book, but now you're going to need to review it just in terms of the head injury information. So on page 853 in chapter 20 of the Starkey book, Starkey gives this examination map. And so if you look at the parts of it, we have already done our determination of consciousness when we did our on-the-field assessment. We've done level of consciousness using Glasgow Coma Scale. We've done primary and secondary survey. And then we did this kind of, well, if the patient is conscious, what is our history that we're going to take? What's our inspection, palpation, functional assessment, and then even a few region-specific pathologies and selective tissue tests. For example, we talked about the halo test. We monitored our patient for deterioration of symptoms to monitor them for diffuse cerebral swelling and things of that nature. So in a manner of speaking, we've been over a lot of things on this injury map. What we're now focusing on is what about head injury, and then we're going to even refine that more to talk about exactly, specifically rather, concussion. Okay, so we're taking this broad concept of head injury, looking at all the possible pathologies we might have, all the special tests, all the evaluation skills that we might employ, but we're going to focus mostly in this unit on concussion. Okay, so other forces that cause head injuries. Let's look at this concept of diffuse injuries. So the brain is shaking around inside of the skull. And the mechanism of injury is that the brain tissue itself is accelerating and decelerating. So it is accelerating because of a force that's induced on it, and then it decelerates when it hits the skull. These can be both acute or subacute / chronic injuries. So your acute injuries can either occur by a direct or an indirect blow. So if you consider this player right here getting hit in the eye and in the front part of her head, this is an example of a diffuse injury because there is an acute direct blow to the head, but it's causing her head to shake around inside of her skull. All right, and so then we could also have in our diffuse injuries subacute or chronic, which would likely occur with a sport such as boxing when you have repeated subconcussive forces, both when the players are practicing and also during bouts. So these are some diffuse types of mechanisms. Again, they can be acute or chronic, and it involves the shaking of the brain inside of the skull. Our focal injuries that are forces rather that cause head injuries are either coup or contra coup. So these are areas then of focused damage caused by a force that's induced on the brain. So the coup is defined as an injury at the site of the blow. You can see the baseball bat hitting the skull right here. I think a better example is a ball such as a baseball hitting the skull, because you can easily see how that's going to create an injury right at the site that the ball hit the head, and not in some other part of the brain, even though the brain may shake around a little bit inside the skull. The contra coup, the injury happens on the opposite side of the skull from the blow. So if we think about a football player making a tackle, they very often hit with the front of their helmet, and when they do that, then the brain is shaken around such that there may be damage at the back of the skull. Okay, so we have contra coup and coup injuries. All right, another force that we have to contend with is a rotational or a shear force. So here on this slide is a great description of what happens when the brain, what happens in the brain to cause a concussion. So in the sport of football, again, if they hit with the front of their helmet, the force is transmitted backwards and it sort of shakes around like this. Okay, so it's bouncing around on the inside of the skull. But also in severe concussions, what they found to be the difference is that there's also this rotational force inside the skull as well, and that's causing more damage. The brain perhaps will swell and cause, as far as being an indicator of a more severe injury. So when you have that rotational or shear force is where you can get a much more severe injury. And again, if the brain does swell, then you're looking at perhaps breathing and other issues, with that rapid onset of swelling. The patient is definitely in a life-threatening condition. So the point of this slide is to say that the rotational or shear force is felt to be the key mechanism of severe concussion. That's just more the brain tissue is not, the axons in your brain are not meant to withstand that force. So they're a lot more damaging. These rotational forces are a lot more damaging. All right, let's move on then from mechanisms and talk about types of head injuries. We've been over a lot of these already, but what I noticed is that I don't think we went over enough of kind of the signs and the symptoms, because you have to be very good at recognizing these. Now, scalp lacerations and skull fractures is pretty easy, but we need to talk a little more in detail about traumatic brain injury, post-concussion syndrome, second impact syndrome, and intracranial hemorrhage, again, so you can recognize the signs and the symptoms. All right, so scalp injuries generally caused by either a tensile compression or a shear force, and the tissue can tear, and that's typically a direct or local problem, and they're very easy to detect. Sometimes the layers of the scalp can separate, and scalp injuries tend to bleed profusely. So we don't have an issue in recognizing these because they're superficial. Okay. Always with a scalp injury, then evaluate for a skull fracture. Make sure that you control the bleeding by and also minimize contamination. We're always concerned about there being a fracture underneath the injury, the superficial or the scalp injury. So we want to avoid compression, clean that and cover it. Sutures are usually needed for scalp injuries. If they gape, there can be infection, and we have to be very concerned about there being a skull fracture. Okay. You may also detect subcutaneous swelling on the skull, which I would imagine would be present in lots of scalp injuries. Okay. All right. So speaking of hematomas and swelling under the skin or on the scalp, this isn't quite on the scalp because it's not over the part where you have hair actually, but we can get a concussion or hematoma because there's such good blood supply to the whole skull. Then you're going to get, it's easy to get a hematoma like this. So it's pooling of blood between the layers of the scalp, and what we want to do is reduce the swelling or bleeding without compression, and that these tend to resolve on their own, just like all other contusions and hematomas. Okay, skull injuries. The mechanism again is typically typically direct, and the patient would have localized pain, so they've typically been hit by something. There can be a compression skull fracture. We don't tend to see those very often, but certainly we're describing a mechanism of injury where some sort of external forces hit the skull. Okay, there are linear fractures, as you can see here in this diagram. That's what I think tend to think of as most general types of fractures in our body. In the skull, we can have depressed fractures and also comminuted. These are really unlikely to occur in sport participation, so we're probably not going to see them. But this is the reason that we want to palpate gently around the area to feel for any depressions in the skull. And then we can also have a comminuted fracture, which are especially dangerous because the little bone fragments can go down into the brain itself and cause a lot of problems. So these would be sort of, mild, moderate, severe in terms of our scale of skull fractures, even though we never call them that. But I think it's easy to see that the comminuted fracture is far more serious. All right, so for a hairline fracture, the patient's going to have some focal pain. There may be some swelling on the scalp, but they'll be a little bit harder to detect. With the depressed fracture, perhaps obvious on evaluation, and may also present with swelling. Definitely not putting pressure on a wound that's in the area where there may be a depressed skull fracture. All right, so comminuted fractures, again, beware of meningeal laceration. They can cause lots of problems in the brain. Other things to consider, basilar skull fractures can happen to the occiput, the temporal bone, the ethmoid, the sphenoid. They're often not full thickness fractures. They can be severe and often fatal. So I don't know if you guys remember Dale Earnhardt, not Dale Jr., but Dale Earnhardt Sr. died of a basilar skull fracture. In that case, you're likely to see CSF in the nose and the ears, and that's when we would employ our halo test to see if there's CSF there. So that is definitely a very severe situation. All right, so with our skull fractures then, you assume that there's a brain injury. So if your patient shows a sign of, say, like a depressed skull fracture, you want to go through your full concussion assessment. Also assume it's comminuted, which means that putting pressure on it is contraindicated. Check their level of consciousness, halo sign, as I mentioned, and battle sign and raccoon eyes. We've been all over that, and we know to look for those things. So increased intracranial pressure should also be monitored if you have a patient with a skull fracture. So anisocoria is the unequal pupils. and the people on the biggest you have to figure out which one is the affected side. So when you're looking at it, someone with two different size eyes, is the one pupil, or is the affected side the side in which the pupil is dilated, or where the pupil appears more constricted? So that's something that you would have to assess to figure out which side of the brain you're on. Also consider this is anisocoria can be congenital. I was telling you guys, I think that my daughter was born with this. So you'd want to ask the patient if they're conscious whether or not their pupils have always been the same size. And if they have, then you're considering that there's pressure on the oculomotor nerve. Other signs of increased intracranial pressure related to a skull fracture, related to a meningeal injury, would be loss of smell, visual difficulties, vomiting, dyspnea, which means trouble breathing, and decreased pulse. Okay. Deterioration of these or other symptoms would also tell you that perhaps there is a skull fracture, and also we're then concerned about there being an intracerebral hemorrhage. So we want to immobilize, control the blood, treat for shock, assess vital signs, and transport that patient. Okay. So speaking of, I said intracerebral earlier when I meant to say intracranial. So intracranial hemorrhages, you can see here. Oopsie, there we go. I gotta wake up my mouse. In diagram A, right here, we're looking at an intracerebral hematoma. So it's actually where the cerebrum itself, the tissue, is experiencing bleeding. That's where the blood is collecting. And then here, where you can see this arrow right here, is an area of an epidural hematoma. So we know already that that's the space in between the dura and the skull. And then we can have too a subdural hematoma, which you can see right here, and it's indicated in this diagram right here. So the subdural hematoma is going to be between the epidural layer and the subdural layer. No, I didn't say that right. In the dura mater and the arachnoid mater. That's what I was trying to say. So that's where the subdural hematoma is, below the dura mater and above the arachnoid mater. Okay, so that's a definition of there being bleeding inside the skull. It's named for the space that it occupies and causes that increased intracranial pressure. We already know that the time of onset will vary. Part of that is because in the epidural space you have arteries, and in the subdural space you have veins, and so the venous bleeding is going to be slower, and so the subdural hematoma can take longer to onset. All right, so I'll refer you back to the signs of increased intracranial pressure, which I have on. Here we go. So we're looking at those pupils, smell, visual difficulties, vomiting, dyspnea, and decreased pulse. And really, we would consider any abnormal cranial nerve assessment to be perhaps indicative of increased or of intracranial hematoma. Okay, so possibly that cranial nerve assessment is positive because of increased intracranial pressure, which can happen when you have an intracranial hemorrhage. Okay. All right, so we've already been over this. I'm going to go over it quickly. The only thing you need to remember about that epidural hematoma is that oftentimes, or the sort of stereotypical MOI, is that the athlete recovers from a blow to the head. Maybe they temporarily lose consciousness, but then they recover and appear normal. And that lucid interval lasts anywhere from a couple of minutes to a couple of hours. Then they become very lethargic and then unconscious. They may have seizures, rapid deterioration of function. So it does onset very quickly, but they can have a lucid period, which is kind of scary because it's just enough time for them to, say, finish a football game, go in the locker room and get changed and get in their car, and then have this epidural bleed in which, God forbid they should be driving, but they could, lose consciousness right away and perhaps die. So that's the one that's really scary. All right, and then the next thing we'll do is talk about traumatic brain injury, but I'll save that for the next slide set.